everyone. My name is Dr. Vaidya Desai Shah. I'm a robotic and laparoscopic gynecologic surgeon and an obstetrician and your mentor for obstetrics and gynecology. So today I have come up with a very important recent update, and this is the updated latest WHO guidelines. That is the guidelines from World Health Organization on the care during labor and birth. All right. So this is all evidence-based guidelines. I'm sharing this video on this updated guidelines for all the practicing obstetricians and gynecologists of the world. Remember that this guidelines, which I am going to discuss, is applicable to all the healthcare settings, whether it is a low resource, medium resource, or a high income country. So these are like the common guidelines from WHO. All right. So in these guidelines, there are a total of 56 recommendations, out of which 30 are the pre-existing recommendations from the previous guidelines of WHO, and 26 recommendations are the new recommendations adopted by the GDG at the 2017 meetings. So these recommendations are categorized into 5 different categories, as the recommendations for the care throughout the labor and birth as the first category. Second category is the care during the first stage of labor. Third category is the care during the second stage of labor, and fourth category is the care during the third stage of labor, and the fifth category is the care of the woman and the newborn after birth, that is the postpartum care. All right, so let us understand all these recommendations in a step-by-step manner. So talking about the first category, that is the recommendations for care throughout the labor and birth. So when we talk about these recommendations, according to WHO, respectful maternity care is the right and privilege of every laboring woman. The right to maintain the dignity, privacy, and the confidentiality of a woman, and also thereby ensuring her the freedom from all the harm and maltreatment, thereby involving her in the informed consent and decision making for her own choices of birth is her right. Second is effective communication. So there must be a very effective communication between the healthcare provider, the nursing staff, and the patient in all the culturally accepted norms, is accepted using the simple language which the patient can understand. Third is birth companion of choice. Remember that every laboring woman has got a right to have the birth companion of a choice during labor who can support her during the process of labor. So these are the recommendations from WHO. Talking about the next category, that is recommendations for the first stage of labor, there have been few updates in the definitions of latent and active phase of labor as per the new guidelines. So according to the new guidelines, the latent phase starts from the time of the painful uterine contractions associated with the cervical changes and the slower rate of cervical dilatation up to 5 centimeters for the first and subsequent labors. So previously this cutoff was still 4 centimeters, but now in the latest guidelines, the cutoff has increased till 5 centimeters. The active phase of labor starts from 5 centimeters of cervical dilatation according to the latest WHO updated guidelines. So this is an important change in the definition of the latent and active phases of labor. Another thing is the duration of latent and active phase of labor. So according to the latest updates, the definition of latent phase can vary widely from one woman to another, and there has not been any establishment of any standard duration for latent phase of labor. Whereas for active phase of labor, this should not go beyond 12 hours in first labors, and it should not go beyond 10 hours in subsequent labors. So the normal duration or the cutoff for the normal duration of active phase is 12 hours in first labors and 10 hours in subsequent labors. So these are few updates in the latest WHO recommendations. Talking about the progress in first stage of labor. Remember that previously WHO used to assume that 1 centimeter per hour cervical dilatation should be the minimum cutoff for the cervical dilatation. But this 1 centimeter per hour is actually fast for many women, right? Especially for the first labors. So remember that the 1 centimeter per hour cervical dilatation rate is actually inaccurate, as shown by this graph, which is actually a study of so many. It is actually a meta-analysis of the women in labor. So according to this, less than 1 centimeter per hour cervical dilatation rate is not an indication for obstetric intervention per se, whether it is for the augmentation of labor or whether it is for any other intervention in obstetrics. Remember that solely a progress in labor less than 1 centimeter per hour is not an indication for the intervention. Or every birth is unique, right? So these are the latest and important updates. So this will help in reducing and cutting off the unnecessary obstetrical interventions. Coming to the other recommendations, remember that the labor ward admission policy is actually still under the research. Okay, no specific recommendations are as such made for this. But the recommendations that are made are the ones for the auscultation using the Doppler, ultrasound, and the Pinard's fetoscope on admission. Remember that upon admission, fetal heart rate assessment is very essential. Digital vaginal examination, which we call commonly as per vaginal examination, should be done at 4-hourly interval for low risk women. Okay, so frequent PV must not be done. And during the labor, intermittent fetal heart sounds with Doppler or Pinard fetoscope is recommended. What is not recommended is the clinical pelvimetry upon admission, the CTG, continuous cardiotocography, the perineal or pubic shaving, the practice of enema upon admission is not recommended. Even continuous CTG in labor is not recommended for low-risk women. All right. Of course, if it is a case of high-risk women, there is a recommendation, and if there is an indication, it is a recommendation. Right. Vaginal cleansing with chlorhexidine is not routinely recommended, according to the latest guidelines. So, a great emphasis has been put on the routine assessment of fetal well-being during labor. So the standard protocol for this intermittent auscultation is that FSH must be auscultated every 15 to 30 minutes for active labor, for the active first stage of labor, and it should be done every 5 minutes in the second stage of labor. The duration of each auscultation should be at least for 60 seconds, that is for 1 minute. The timing of fetal heart rate auscultation is during a uterine contraction and for at least 30 seconds after the contraction is over. Remember that the recording should record the baseline as a single counted number in beats per minute, and the acceleration or deceleration must be noted. So this is a standard protocol for intermittent auscultation to be followed as per the WHO guidelines. Talking about pain relief during labor, the recommended options as per the WHO guidelines for pain relief during labor include epidural analgesia, opioid analgesias like pethidine, relaxation techniques like music, the various other techniques like manual techniques like balloon or something, and oral fluids intake and food intake is allowed in for pain relief during labor. Even simple mobility is recommended for pain relief during labor. What recommendations are not done, especially for prevention of delay in labor, are the pain relief. Giving analgesics only to prevent delay in labor is not recommended. Active management of labor, amniotomy alone, or early amniotomy with early oxytocin augmentation with epidural analgesia, IV fluids antispasmodic agents only for prevention of delay in labor is not recommended by WHO. Coming to the next category, that is recommendations for second stage of labor. Talking about the definition and duration of second stage of labor, the definition of second stage of labor is the period of time between the full cervical dilatation till the birth of the baby. That is actually the second stage of labor. The normal duration or the cutoff for the second stage of labor is, in first labor it is 3 hours, in second labor it is 2 hours. So the second stage of labor should not go beyond 3 hours in first labor and beyond 2 hours in subsequent labors. Coming to the next category, that is recommendations for third stage of labor. So in the third stage of labor, remember that the uterotonics are recommended for prevention of PPH. And the WHO recommended uterotonic of choice is oxytocin, 10 international units, IM or IV. Remember that this is the first choice uterotonic by WHO. In situation where oxytocin is not available, in that situation, misoprostol 600 microgram oral route or combination of methyl ergometrin are the other alternatives, or any other prostaglandin analogs are also allowed, only when oxytocin is not available. Timing of the umbilical cord clamping. According to WHO, delayed umbilical cord clamping is recommended. Remember that at least 1 minute after the birth, cord clampers be placed. This will significantly improve the neonatal and the infant outcomes, and it has got a positive impact on the fetal health and the nutrition outcomes. Especially, it has got positive correlation with reduction in neonatal anemia and sepsis. Right? About other recommendation is the placental delivery by controlled cord traction by modified brand adherence technique is recommended. And regarding uterine massage, remember that uterine massage is not recommended by WHO. However, intermittent uterine tone assessment is recommended by WHO. Recommendations for care of the newborn. Remember that the routine nasal or oral suction is not recommended by WHO. Encouragement of early skin-to-skin contact, breastfeeding, then vitamin K, which is the prophylaxis against the hemorrhagic disease of the newborn, is recommended by WHO. Regarding bathing of the newborn, at least a delay of 24 hours is recommended by WHO. However, due to the culturally accepted norms and traditions, if delay until 24 hours is not possible, at least there should be a delay of 6 hours for bathing of newborn recommended by WHO. The recommendations for the postpartum care of the woman include monitoring the vitals of the female, along with monitoring the vaginal bleeding, uterine contraction, fundal height, temperature, pulse, blood pressure, and urine output of the female. So these all things must be recorded in the postpartum care of the woman. So a woman should have voided at least within 6 hours after her birth. Other recommendations for the postpartum care of the woman by WHO include uterine tone assessment, and according to WHO, after an uncomplicated normal vaginal delivery, the woman should be kept in the hospital for at least 24 hours, and discharge must be done only after 24 hours after normal vaginal delivery. What is not recommended as per WHO is the routine antibiotic prophylaxis given for episiotomy and the routine antibiotics for the uncomplicated vaginal birth. Remember that these practices are not recommended as per latest WHO guidelines. So this are a total of 56 recommendations in total, and these are the latest updated guidelines by WHO. Thank you all for your patient listening, and I want to share this knowledge to all the obstetricians and gynecologists of the world so that we stay updated in practice. Good luck. Thank you.